Good evening, everyone, and welcome to the webinar on the theme Oncology Updates. It gives me great pleasure to invite our Program Director, Dr. Muzammil Shaikh, Director, Medical Oncology, Nanavati Max Super Specialty Hospital, Mumbai, to give the opening remarks. Over to you, sir.
Thank you, Manshi. So I welcome you all for this, important scientific update. Very well planned, the theme today evening about oncology update. I will thank ISCO and Astra for this opportunity. And we know that the testing of HER2 as such has gone a sea change from binary yes and no to more than binary today. We have 3 to 4 subtypes of HER2 testing. We have Dr. Pravin Mahajan, who is an expert histopathologist, who will be discussing about the testing of HER2, especially the HER2 low and the HER2 ultra low. And eventually, we will discuss about the impact of this HER2 low and ultra low in treatment decision making in 2025. But we will start first with the state of the art treatment of HER2 positive MBCs, and then there will be a session on colorectal by Dr. Kaushik. So I will invite today's first speaker, our dear friend Dr. Jyoti Bajpai, who's a lead medical and she's in charge of the medical oncology unit and precision oncology at Apollo Hospital. Uh, Dr. Jyoti, welcome.
Thank you, Muzammil. We are meeting more often.
Yes, that's a good sign. So
That's a
I
good
will hand
sign.
over to Jyoti to just take
Yeah,
us through the treatment paradigms. Thank you.
perfect. Sure. So I will share my slides, please. So slides are visible, right?
Yes,
Yeah.
ma'am.
Sure. So in next few minutes, we should be discussing about this very important topic, very much therapeutically relevant and very revolutionizing, I would say. And my colleagues would agree that, in the armamentarium, as we are having more and more drugs, more and more players, which are showing, real separation of curve, we are more excited and we are happy that our patients are having more options. So we'll briefly discuss about the background, the unmet need in hormone receptor positive, HER2 negative metastatic breast cancer, and HER2 mechanism of action. Then the trial data, Destiny Breast 06, the design, efficacy, safety, health related quality of life data, which is very, very important. And a little bit, I will touch upon the adverse event management. And then, of course, the summary and recommendations. So the majority of HR positive cancers, as we know, sorry, slides are having their own mind, I believe. So the majority of hormone receptor positive HER2 negative metastatic breast cancer express clinically meaningful levels of HER2, and guidelines recommend that we should assess HER2 status in all newly diagnosed patients with breast cancer and those patients who develop metastatic disease as well. So HER2 2 plus, HER2 2 plus can be IHC 3 plus, 2 plus FISH positive, which is 15 to 20%, while HER2 negative, which is, hormone receptor positive, and HER2 negative conventionally, which is again HER2 1 plus, HER2 0 plus, and actually, HER2 truly negative. So this HER2 low and ultra low subset now encompasses somewhere around 65%, which is very, very, big segment, I would say. So there we are, and that's what there is brainstorming and deciding upon that how to deal this specific subgroup. So Destiny 06 targets low and ultra low HER2 expressing tumors in metastatic breast cancer. And just to rebrush that, IHC 2 plus and FISH negative, when we say weak to moderate complete membrane staining in more than 10% of tumor cells, and IHC 1 plus is faint and incomplete membrane staining in more than 10% of tumor cells. And in IHC 0, again, there are two subsets, one faint incomplete membrane staining in less than or equal to 10% of tumor cells, which is IHC 0 with membrane staining, while there is a true absent membrane staining, and it is actually the true, a negative. So this is the spectrum, and this is an unmet need, because we know that, when we see the current treatment landscape and outcomes, especially the median PFS, we see that in first line, if we give endocrine therapy with CDK4/6 inhibitor, and if there is no prior CDK4/6 inhibitor exposure, then we cross 2 year. But if it is second line and the endocrine therapy with targeted therapies in the patients who have prior CDK4/6 exposure, it is less than 6 months. And ET monotherapy is having only 2 to 3 months kind, which is really kind of concerning. In third line plus single agent chemotherapy, if they are mostly chemotherapy naive patients, then it is 6 to 7 months. And TDXT, even if it is prior endocrine or chemotherapy exposure, then also it is 10 months plus. So we definitely need more efficacious targeted therapies and also earlier in the treatment pathway, as we can see here. So what is the mechanism of action of this particular drug? TDXT it causes bystander anti-tumor effect, and this is a rationale for targeting HER2 low metastatic breast cancer. So we can see that there is a highly potent topoisomerase 1 inhibitor payload, and there is an 8:1 drug to antibody ratio and tetrapeptide-based cleavable linker. And we can see in this cartoon that how this drug act, and majority of the people who are present here, they know that internalization of TDXT leads to release of the TDXT payload and subsequent cell death in the target tumor cell and also in the neighboring tumor cell through this bystander anti-tumor effect. That's where the efficacy becomes better. So now we'll focus on the Destiny Breast 06 background, the study design. So this is an open label randomized multicenter phase 3 study, and patient population essentially comprises of hormone receptor positive metastatic breast cancer, HER2 low, as I just defined in the prior slide, like IHC 1 plus or 2 plus, FISH negative, or HER2 ultra low. So that is her IHC 0 with mammary staining. Very interesting. Chemotherapy naive in the MBC setting, prior line of therapies permitted were more than equal to or more than 2 lines of endocrine therapy plus minus targeted therapy, or 1 line for MBC and progression in less than or equal to 6 months of starting first line endocrine therapy plus CDK4/6 inhibitor, or recurrence in less than or equal to 24 months of starting adjuvant endocrine therapy. So this is the population, and the stratification factor were rightly prior CDK4/6 inhibitor use, yes versus no, HER2 expression. So gradation, IHC 1 versus 2 versus IHC 0 with mammary staining. So whether there is a spectrum, and prior taxane in the non-metastatic setting. So the endpoints were so TDXD versus physician's choice, and they were HER2 low, which were predominant 7 month 3, while ultra low is also just 153. So primary endpoints were PFS and HER2 low, and key secondary endpoints were PFS and ITT, and OS and HER2 low, and OS and ITT. There are other secondary endpoints also, including of response rates, safety, tolerability, and patient-related outcomes. So this is the demographics and key baseline characteristics. And we can see that in the 2 arms, generally, they are well matched as far as the gender is concerned, the age is concerned, the race is concerned, the region is concerned, and ECOG performance status. This is the HER2 expression, which is again, we can see it is matched, and ERPR status, primary endocrine resistance, stage 4 disease at diagnosis, bone-only disease versus visceral disease, liver metastasis, which is important, brain or CNS metastasis, which is in HER2 low population was around 9% versus 7%, and in ITT population is somewhere around 8.5, 7.7. So they are generally matched between the 2 arms. Prior therapies in the metastatic setting, the lines of endocrine therapy. So median range was 2 in both the arms, and again we can see that first line with less than 6 months or first line endocrine therapy with CDK4/6 inhibitor versus 2-3 lines, they're generally well balanced characteristics. So this is the PFS in HER2 low primary, which is the primary endpoint, and we can see that these curves are really separating well, and there is a good delta of 5.1 months with respect to physician's choice, and this is crossing an year in TDXD, which is which is assuring, and with hazard of 0.62 and p-value of 0.001. So TTXT demonstrated a statistically significant and also meaningful improvement in PFS compared to standard of care. Yeah. And it demonstrated a consistent MPFS across pre-specified exploratory subgroups, which is again assuring, especially with related to age, HER2 expression, previous CDK4/6 inhibitor use or taxane use, or previous line of therapies, or with respect to endocrine resistance, or what was the comparator arm? Because it was physician's choice, it could have been anything like capecitabine, taxanes, etc. And with the presence of liver metastasis versus no. So PFS in OA is in HER2 ultra low, which is again a pre-specified exploratory analysis. Interesting. And here also we can see a good hazard of 0.78 and a good delta of 4.9 months. And again, TDXD crossing in a year, which is kind of comparable to HER2 low, with what we have seen. And so there is a PFS improvement in both low and ultra low we have seen. And the overall response rates and best overall response based on BICR. So this is confirmed overall response rates and clinical benefit rates. We are seeing median duration of responses. So they all are better in TDXD in HER2 low and as well as HER2 ultra low. So TDXD demonstrates significantly higher response rates with over half responding versus 1/3 with chemotherapy, and showed uniform efficacy across the spectrum of ultra low and low, which is really assuring, in this kind of population. So PFS by time to progression on one line endocrine therapy plus CDK4/6 inhibitor and endocrine resistance. So we can see in these graphs that TDXD improved PFS versus physician's choice regardless of time to progression on first line endocrine therapy plus CDK4/6 inhibitor or type of endocrine resistance. PFS2 in overall ITT population. So we can see that a delay in PFS2 was clinically meaningful in favor of TDXD. And, this is the data which is showing here. PFS by measure of disease burden. So PFS benefit for TDXD was observed regardless of disease burden, with notable efficacy in patients with low disease burden even. And so this is like visceral disease, liver metastasis, baseline tumor size, all across we can see that there is a benefit which is mounted. About the safety, very, very important. So this is the overall safety summary. The most common treatment-related adverse event associated with treatment discontinuation in TDXD arm were 5% plus pneumonitis. We have to be careful about this complication and really preempt and monitor very well our patients so that we can avoid this or pick very early. And in physician's choice, it is mainly peripheral sensory neuropathy, which we know that in many of the chemotherapy we find this is quite common, and all the time there's a crippling complication of peripheral neuropathy, sustained, prolonged in our patients. Most common treatment-related adverse events associated with dose reductions were nausea, that is in TDXD 4% plus. So again, very important, and this is a strongly, highly emetogenic drug, and we require triple antiemetic coverage. Even, I prefer to add an olanzapine to my patients, like highly emetogenic chemotherapy. And for the physician's choice, it is it depends upon which drug we are giving, and that's how the side effect profile emerge. So exposure adjusted incidence rate of treatment-related treatment emergent adverse events we are seeing here, that TDXD versus TPC, and essentially we can see that there is treatment-related associated deaths were there in 5 patients, that we have to see 1.2% in overall population. So that is something which we need to see and be very careful while we are using these important therapies. And what is the reason of discontinuation or dose interruptions we have seen? It is somewhere around 12% of permanent discontinuations and interruptions in almost a third. So that is what we have to be carefully seeing. This was, but one important thing is that the safety profile was consistent with the worst was seen in Destiny 04. So there is no new signals which were seen, and it is, the majority of the side effects are manageable. And if we carefully select our patients and monitor them well, then perhaps we can avoid the severe grades of complications. The special interest drug-related pneumonitis, as I said before, the median time to onset of adjusted ILD or pneumonitis is 141 days. And of the 49 patients with any grade adjudicated ILD pneumonitis in the TDXD arm, 20 were reported as having recovered, 2 were reported as recovered with sequelae, and 3 were reported as recovering at DCO. In the physician's choice arm, the ILD or pneumonitis occurred in 1 patient only. This was a grade 2 event that resolved after treatment discontinuation. So this is again an important thing which we have to be carefully seeing. Ejection fraction decrease was of any grade was seen in 8% in TDXD versus physician choice in around 3%. And cardiac failure was actually 0 in TDXD, but in physician's choice, there were 3, which of any grade. So this is the health-related quality of life, which in my opinion is very, very important, because mean change from baseline in quality of life over 31 weeks or until progressive disease, whichever is early in ITT population. So despite the treatment with HER2 was almost 2 times longer, like 11 months versus 5.6 months, patients on HER2 maintained overall health-related quality of life, as we are seeing in this graph. So that is something important. So though there were nausea and vomitings, but they were not so much detrimental that they are affecting directly quality of life. So they are manageable. So that is important. So what is, to conclude, TDXD demonstrated statistically significant and clinically meaningful. This meaningful, in my opinion, is more important, PFS benefit versus physician's choice, which was conventional chemotherapy in HR positive HER2 low Mbc in an earlier line of treatment than Destiny 04. Results in HER2 ultra low were consistent with HER2 low. So both these populations we can target with this important drug. There was confirmed overall response rates around 57% with TDXD versus 31% in physician's choice in ITT. So we can get good responses, because many times we aim to achieve fast response in these patients, especially when there is a visceral involvement of significant degrees. No new safety signals were identified. Interstitial lung disease remains an important safety risk, a word of caution, and we have to be carefully preempting and managing this complication. So this particular trial, Destiny 06, establishes TDXD as an effective new treatment option for patients with hormone receptor positive, HER2 low and ultra low MBC following one line of endocrine-based therapy. So with this, I would just briefly touch base upon the adverse event management. So this is an emetogenic, and as I said, pre-medication with antiemetic agents during treatment is highly recommended, and especially, the MASCC ESMO guidelines suggest that we have to use in day 1 to prevent acute CINV 5-HT3 receptor antagonist, NK1 receptor antagonist, and dexamethasone, and day 2 to 3 to prevent delayed CINV, NK1 receptor antagonist. So real-world studies indicate greater control when HER2 related and nausea and vomiting with 3 versus 2 drugs. So at least 3 drugs. And in practical world, I would say that if you add a 2.5 milligram olanzapine, our own TMH study, which suggested even 2.5 milligram olanzapine is equivalent to 10 milligram olanzapine in a randomized controlled trial, Lancet Oncology publication. So that 2.5 milligram also adds a lot of value, and these patients are pretty comfortable. That's what with highly emetogenic therapies like this. So the important side effect, ILD pneumonitis, and we have to be very, very carefully monitoring signs and symptoms of this important complication. Cough should not be ignored, and cough, dyspnea, fever, new or worsening respiratory symptoms, everything should be carefully watched. And I think frequent monitoring is the key, and counseling patients well that when they should report to us. So if the healthcare practitioners, are aware of the risk and promptly identify and report, symptoms, if the patient and the caregivers to them, report to physicians promptly, then we can manage them appropriately. So I think high index of suspicion, proper counseling, and frequent monitoring is the key. So this is the guidelines and recommendation for the multidisciplinary diagnosis and management of ILD. So if it is grade 1, then HER2 can be resumed if the ILD pneumonitis is fully resolved to grade 0. If it is resolved less than 28 days from the day of onset, then maintain dose. If more than 28 days after, then we should reduce to 1 level. And if the grade 1 ILD event has not resolved within 18 weeks, like 126 days even, then we have to discontinue. So one should monitor closely, follow up, and every 2 to 7 days, depending on the severity, and follow up imaging in 1 to 2 weeks. Consider starting systemic steroids at the 0.5 milligram per kilogram per day, prednisolone equivalent until improvement, and then gradual taper over a month. And if it is grade 2, then permanently discontinue HER2, and management is more vigorous with the systemic steroid more than 1 milligram per kilogram per day, and for 14 days plus, and then depending upon how it is going, we can taper. And if it is still worsening, then we may increase or the dose of steroid 2 milligram per kilogram per day, or switch to IV methylprednisolone, or even at times further escalation. If it is for even more severe, then permanently discontinue for sure. And we can use high dose methylprednisolone like 500 to 1000 milligram per day for 3 days, and then the standard way, monitor taper, etc. And at times we may require other immunosuppressants also, like infliximab or mycophenolate mofetil, or as per the local institutional practices. And of course, I believe in multidisciplinary management. So I think pulmonologists, other experts can be on board to salvage the patient better. So lung examination, so monitor resolution, baseline, and periodic is important. Lung examination including checking for cough or shortness of breath. Respiratory function testing is important. Oxygen saturation by pulse oximetry before every cycle, and high resolution computed tomography as and when needed. So I think regular assessment and patient education is the key for early identification via proactive self-monitoring. And, everybody should be versed. And I think lung assessment and then the SpO2 prior to each treatment every 3 weekly. Consultation with oncologist every 4 to 6 weeks is recommended, but we see as, in each cycle, that's how, it's better. So I think summary and recommendations that HER2 outperformed chemotherapy when used post second line of endocrine therapy and demonstrated a favorable benefit risk profile in patients with hormone receptor positive, HER2 low and HER2 ultra low metastatic breast cancer. There is 13.2 months MPFS versus 8 months with chemotherapy, and secondary endpoints like responses 56.5% with HER2 versus 32.2 with chemotherapy. So clearly superior in this population, and it is efficacy is in the exploratory HER2 ultra low was also consistent as was in HER2 low. So this is a impressive data, and we need to identify eligible patients and monitor them well so that we can offer them this kind of therapy. This is the ESMO Living Guidelines 2025, and we can see that patients with hormone receptor positive HER2 negative MBC who are not candidate for endocrine therapy or plus minus targeted, if there is prior chemotherapy for metastatic breast cancer already received, and if it is HER2 low, trastuzumab deruxtecan, category 1A recommendation, MCBS4. Sacituzumab govitecan is also similar platform, and datopotamab deruxtecan is also, but it is a logistic challenge is that for other drug. So datopotamab. And if it is no prior chemotherapy for MBC, if HER2 low or ultra low, trastuzumab deruxtecan again category 1A, but MCB is here is 3. Chemotherapy is again category 1C. So that is also an option. And with all this, if there's a progression, so if not used before, again, trastuzumab deruxtecan can be tried in second line also. Again, sacituzumab is also an option. And datopotamab deruxtecan again is an option. So this is the living guidelines. We are having more players in the armamentarium, and that's how this is the NCCN guidelines, kind of similar. We can see that first line, no germline BRCA1 mutation, and IHC HER2 0+, 1+, or 2+. Then systemic chemotherapy category 1 or farm trastuzumab deruxtecan is also got place here. And if it is a BRCA1 mutation, then PARP inhibitors. In second line, in all these category HER2, IHC 0+, 1+, or 2+, trastuzumab deruxtecan category 1 preferred. And if it is not a candidate, then other drugs like sacituzumab or chemotherapy, other targeted therapy, etc. Third line and beyond, if it is, it can be chemotherapy or targeted therapy depending upon what they have received before, what is a biomarker, etc. And several other options could be there. So with this, I would end, and I'll hand over to the organizer for taking it forward.
Yeah. Thank you, Jyoti, for that, excellent review of this topic, and also stressing more upon how to manage these, side effects of this new drug, which is very, very important, which is missed in most of the talks. We talk about the efficacy, but no one talks about the side effects and the side effect management. Very heartening to see that a lot of options are there for this subgroup of patients, and also the way we are testing has changed now. So with this, I will like to invite our next speaker, Dr. Pravin Mahajan. He's a very dear friend of all of us, an excellent pathologist. He will be speaking about, HER2 low and ultra low testing in breast cancer. Hi, Pravin.
Hi, Ali bhai.
So all of, yeah,
I have been calling Muzammil Ali bhai only since our college days. So
you
yes.
continue this.
Thank you for the
Take care.
introduction,
Yeah.
and I will share my PPT. So basically, today I'm talking about, is my PPT visible?
Yeah, just make
No,
it
I
full
think,
screen.
right?
Yeah, just make it full
Yeah,
screen.
okay. So
Yeah,
I'm going to
thanks.
give you some overview about, thank you, about what is has changed in this HER2 diagnosis, like what we used to report, what now we are supposed to report as a pathologist, and what has changed in specifically what is the how we make the diagnosis of HER2 low or ultra low in a breast cancer. So there are things which have changed over the years when this HER2 testing has changed. Like, if you go to pre-2007 era, we used to have HER2 positive score, which was 3+. When we used to see that under the microscope, if there is a strong complete membrane or intense membrane staining in more than 10% of cells, and we just used to say it is HER2 positive. Rest of the things we used to call it negative. In 2007, what happened is the ASCO cap had concern about having some high false positive rate in this, when we were making cutting, when cutoff was 10% of the cells. That's why they changed the 3+ category, means when we are going to make diagnosis of 3+, they said now you have to see that at least 30% or more of the cells should show this intense, strong, complete membrane staining in the tumor cells. That was in 2007. Now, again in 2013, they again had some concerns which were raised regarding the false negatives, and then they introduced some guidelines for ISH, that is in situ hybridization. And again, for a ISC interpretation, the 3+ category was again brought down to this cutoff of what was there in 2007. Which is more than 10% of the sales. So from 30% to 10%, they again brought down that cutoff, and then we started calling anything 3+ when there is more than 10% of cells showed strong and complete membrane staining. In 2018, they come up with guidelines for each equivocal results. So the results which on ISC we call 2+, That means the weak to moderate staining, complete staining in more than 10% of cells, which is not strong or intense staining. We used to call them equivocal or borderline. And those cases, you need to do the reflex each testing, be it a fluorescence in situ or maybe chromogenic in situ hybridization. And they came up with this guidelines in 2018. Then German guidelines came, published their own guidelines regarding the actually then from here on the HER2 low guidelines started coming. That was followed by France guidelines coming from the France. Again, they gave some new guidelines for how to score the HER2 in IHC and particularly about the HER2 low. In 2023, ASCO CAP came up with guidelines for HER2 testing, and then there they stressed the relevance of scoring something which is IHC 0 versus 1 plus scoring. So those were which we used to call all negative. Now they said that you have to make the distinction between 0 and 1 plus. You can't just call it negative. Similarly, in 2023, ESMO, that was the European guidelines which came regarding the same thing about HER2 low, added that about how to diagnose HER2 low or rather HER2 1 plus and 0 and between 0 to 1 plus. And so that's how it has changed over the years. And it is, I mean, if you see the recent years, it has fastly changed. So what we were doing earlier, like this is ASCO CAP guideline 2018. So as I said, 3 plus we used to say when there was a complete intense membrane staining in 10% of the tumor cells. We used to say anything equivocal 2 plus when there was weak to moderate complete membrane staining observed in the 10% of the tumor cells. And these cases actually went for a reflex testing by ISH to say if those are amplified or not amplified. If those are amplified, then they went to do the category of HER2 positive. And if those were negative, if they were not amplified, and then they were put into the negative category. Now the IHC 1 plus, which you say, had a definition that it is incomplete membrane staining, which is faintly or barely perceptible in more than 10% of the cells. And anything less than that was categorized as 0, that is negative, or 0. That means either there is no staining at all, there is no membrane staining at all, or if there is a membrane staining, which is incomplete or faint, barely perceptible, but that has to be in less than 10% of the tumor cells. That was what we were practicing. So, so if I had to give you this, like what we were classifying into only two groups, like a binary classification. One was a positive, HER2 positive cases, and which were the HER2 negative cases. So HER2 positive, as I already mentioned, one ISC, which were 3 plus, those were directly HER2 positive. You didn't need to do any reflex testing. But those who were 2 plus, you do reflex testing by ISH, and those who positive were pushed into HER2 positive. Those were negative is pushed into HER2 negative. And that's what the HER2 negative actually composed of, which means the 0, 1 plus and 2 plus, which is ISH negative. That's what we were doing for this binary interpretation of the HER2 protein expression, or even IHC negative, ISH negative. Then what do you mean by HER2 low? So HER2 low things started coming after Destiny 4 trial, and what happened actually that the HER2 positive remained the same thing, but in the negative category, which is HER2 negative, which had score 0, 1 plus and ISH negative 2 plus, we started making into the two things. One is HER2 low and other is HER2 negative. So HER2 low, which were defined as the 2 plus equivocal staining on IHC, which on reflex ISH negative for amplification, they were also called HER2 low. And whatever on ISC expression, which was we used to call 1 plus, they were also pushed into HER2 low category. And anything less than that, now they were calling it HER2 negative ISC 0. So subsequently in 2021, as I already mentioned, that the first guidelines for HER2 change for regarding this HER2 low came from actually from France, and they updated this practice of HER2 low classification. And what they said that there are some recommendations they give, that there are 4 recommendations which were there, like they said that you have to explicitly record details of HER2 staining characteristics and the resulting IHC score, that you must mention IHC 1 plus or IHC 2 plus, which is ISH negative, and then classify them as a HER2 low. Like means I'm going to write in my report saying okay, this is 1 plus, and in bracket, this is considered a HER2 low. Or if it is IHC 2 plus but each negative, then again I am going to classify them as a HER2 low. Then they gave some recommendations on the testing and retesting of HER2 in invasive breast cancer at the time of diagnosis, at the time of recurrence also, and at the time when there is a metastatic relapse. Or if for some reason, for a technical reasons, if some policy negative result was suspected in the whatever test was done, then they again recommended that you may do testing or a retesting. They also recommended that the all labs should use calibrated controls. That means when I'm seeing the HER2, along with that HER2 test, I should be running the controls, and those are all calibrated controls, and those controls should have all the different type of this 0, 1 plus, 2 plus, or 3 plus, so that you are quite sure that whatever you are doing is appropriate. And then also they gave explanation why HER2 low is important in the context of this emerging therapy, which is TDXT, and we all heard about it from Dr. Bajpai. So that's what the first recommendation came from in 2021 from German group. Till so after that, in UK they updated the guidelines, and again that was again for HER2 low and for the approval of HER2 targeted anti-drug conjugate, and they again gave some guidelines to the pathologists for refinement of the scoring, how to accurately identify basically for HER2 low tumors. Anyways, the HER2 positive has not changed, so it was all about the negative ones, how to classify them into HER2 low. And so they talked about providing focused training and recognizing the training intensity as well as different patterns across the full spectrum of HER2 expression. And then, as a pathologist, for the pathologist, actually, they said the magnification rule. The magnification rule, what I'm saying here is a magnification of the microscope we are talking. We have different lenses in the microscope, like we say 4x, 10x, 20x, and 40x. So this is what magnification they were saying. So the thing was that the 3 plus IC on microscope, which is evident only even on the very low power, like a 4x also. So you see intense staining, and I can make that diagnosis 3 plus. Now for 2 plus, you can still see it on a low power, or you may go on to little high power like a 10x, and then I can make it 2 plus. But when you are debating between something to called 1 plus or 0, you need to go on a high power like 40x or 20x and beyond, and 40x. That's what they come up with the recommendation that the pathologist should not be making the diagnosis of 0 or 1 plus, and if you're not sure, you should go on the high power and check, and then only release the report. Again, they talked about the control preparation similarly to what the French guidelines were. And obviously, reflex IHC was just the same thing, like it was required only when it is IHC 2 plus. And then they said include HER2 low classification when you have IHC 1 plus or IHC 2 plus, which is each negative, in your report, and say that these are patients can be available for this HER2 targeted ADCs. And then in 2023, Germany and the German pathologist coming with the recommendation regarding the same thing. This was again to talk about how to distinguish basically those HER2 negative group. That means 0 and 1 plus. In that, how do you make something which is HER2 low? And so this group clearly identified, they recommended that this group should be clearly identified, and we recommend the use of term HER2 low. So this is what they said, that as of now, even ASCO CAP guidelines, which I will come to, they still don't mention that you should write in your report HER2 low. They just say that you just write what it is there, and then in comment you may say that these patients are eligible for the treatment for HER2 low tumors, which is whatever this TDXT treatment is there. Again, they talked about this standardized HER2 assessment for the external quality control trials to include HER2 low tumors. And again, they said that for the primary tumor or for a re-biopsy of the metastasis can be used for the determination of HER2 low status if you don't have actually primary thing or it has relapsed or recurred. So the two most important recommendations then came on HER2 low in June 2023. There are two different guidelines. One came from Europe, which we know that this is called in ESMO consensus. And other came from ASCO CAP guidelines regarding again HER2, basically to make pathologists aware that there is something called as HER2 now, and they gave some recommendation how to report it, what to see it, how to do it. All those are there. Those which are interested, if there are pathologists, they can go to all this in details and check. But this is what it is. If you look at the ESMO guidelines, they actually use this HER2 low for clinical practice for cases determined as HER2 1 plus HER2 plus according to definition using Destiny Breast 404 for clinical trial. Now, I just want to make the point here for all the oncologists who are listening that when somebody is going to say whether it is 1 plus or 0 plus or low, either HER2 low or ultra low, one should always check what clone this pathologist is using, because whatever this has been told about HER2 low, this has been done on a particular platform which is called as Ventana platform, and they had used the antibody what is called as 4B5 antibody in these trials. So if your pathologist is using some other antibody or some other platform, then by definition you cannot call it HER2 low, because this is a sort of companion diagnostic, even though they don't explicitly say it that this is like a companion diagnostic, like a PDL1, like a 22C3, which is done in a DACO platform, is like a companion diagnosis. This also they don't say so explicitly for this HER2 low, but it is like that. So pathologists should be reporting HER2 low only if the HER2 is being done on a Ventana platform using antibody 4B5. Okay, so in ESMO, what they actually did is that the HER2 positive group remained the same thing, but in a HER2 negative group, what they separated is HER2 low, which I already mentioned is the same thing. And even in HER2 0, they actually have now said that those which do not show any membrane staining should be called HER2 null, that means 0. And those who show some faint staining in less than 10% of the cells should be called as HER2 ultra low. I mean, I'll come to that again. So this is what the ESMO came up with the guidelines to say that you need to see the cases carefully, make the interpretation properly so that you are not just saying it is negative, but whether these are 1 plus or 0 plus or it's completely 0. And in 2023 update from ASCO and CAP, the same thing was reiterated. They gave some guidelines for pathologists how to, that the pathologist should make efforts to distinguish 1 plus is a result from 0 by following good laboratory practices. So what are those laboratory practices? They told, I mean, they have emphasized that you have to examine HER2 IC stains with using standard ASCO guidelines for scoring criteria. Examine HER2 IC at high power when you are trying to discriminate between 0 and 1 plus staining. And it is also a good idea that the second pathologist looks at the result. If you have something which is close to 0 versus 1 plus interpretive threshold, and so this recommendation came earlier. It was only for like a 2 plus. They had said like if you're going to call anything 2 plus and you have not sure whether it is 1 plus or 2 plus, I mean, at least there should be two different eyes which are looking at the stain and confirm whether it is actually a 2 plus. But now it has come even for 0 to 1 plus. And of course, they said that use controls which has a different range of protein expression, which also includes 1 plus, so that this assay can then detect the limit of detection of the test. And of course, they always have mentioned in earlier guidelines also that there should be a careful attention to pre-analytic condition of breast cancer tissue samples for both primary and metastatic sites. Like that means sample should be immediately fixed. It should be fixed in 10% buffered formalin. So all those pre-analytic conditions, that there should not be cold ischemia, more than whatever thing they mentioned. So those guidelines are still valid for even these new guidelines. So they also recommended that pathology labs should include a footnote in their HER2 testing reports that whether you have done IC or in situ hybridization, and the following recommendation they have put it as a comment. And I'm going to read it. It says the patient with breast cancer that are HER2 1 plus or HER2 IC 1 plus or IC 2 plus, which are each non-amplified, may be eligible for treatment that targets non-amplified or non-overexpressed levels of HER2 expression for cytotoxic drug delivery. So IC0 results should not do not result in eligibility currently. So as of now, here they recommended that IHC 0 are not eligible for this kind of treatment. So this is what the guidelines came in 2023, and then I have just read the comment about it, which is given in the best practices recommendation of this. This is for the pathologists actually, that there are 3 things they need to check on the different magnification of the microscope. Like one is intensity of the staining, the completeness of the staining. That means when I'm saying completeness, means the complete or circular membranous cytoplasmic membrane staining of the HER2 IHC. And the extent of staining means the percentage of the tumor cells which are then seen. So if you take into consider this like ICE framework, intensity, completeness, and extent, you will be able to categorize most of these into into the different categories, which is HER2 low categories. So this is what again given for pathologists only. So I'm not going to read about it. And this is for pathologists. Anybody is there, they can take screenshot and see later on. It is available on the net also. So what is ultra low? HER2 ultra low. So we have talked now, the Destiny 4 talked only about HER2 low. Then after Destiny 6 trial, what started coming is ultra low. So the category of something which was less than 1 plus, they wanted to know if the patients will benefit from the therapy. If you can define something in this category of 0, so whether there is 0 no membrane staining, or some patients which are showing just membrane staining incomplete in less than 10% of cells. And basically we know why they did, and Dr. Bajpai has already mentioned that what was the trial about and what therapy they were giving. So what, as a pathologist, what we learn from here is that in Destiny 6 trial, what now they said, not only that you have to define HER2 low, but now you have to, from HER2 low, you have to separate ultra lows also. So you have to be more the important, the more better evaluation you'll have to do for HER2 expression, so that the patient can be eligible for this TDXT therapy. So this is what happened. HER2 3 plus and 2 plus, which are amplified, remain positive. In HER2 negative, ish negative, and HER2 1 plus remain HER2 low. But in a 0 category, which we are saying, they brought out a category called HER2 ultra low. So that is HER2 ultra low. And when there is no membrane staining at all, nothing, then it is HER2 null category. So if you have to define HER2 ultra low, what it means, that the less than 10% of the tumor cells show membrane staining, which is incomplete, faint, or barely perceptible. Okay. So if anything more than 10%, then it is 1 plus. But if it is less than 10%, then it is called as HER2 ultra low. And HER2 negative completely, or HER2 null categories, when there is absolutely no membrane staining at all. And there are other recommendations also, in ASCO-CAP guidelines, those pathologists, if somebody is joining, they should go and check, because there are a lot of things they are told when to say it is a membrane staining, when to say it is not a membrane staining. So those guidelines are also there when there is some granular staining, or there are a lot of things which have been there, and I'm not going to describe it here because this is not the platform for that. But if there are pathologists, I would recommend that they should go into the details of these guidelines. So the template for CAP reporting for the patients of carcinoma of breast, where you are doing HER2 by IC, they have now again given this recommendation, like in negative score 0, if there is no membrane staining, you have to say it is 0 or absent or no membrane staining. If I have already mentioned that you say something is 0 plus with membrane staining, or ultra low when there is barely or imperceptible incomplete staining in less than 10% of cells. And then they are given some footnotes and comments which you need to add. So this is what now has changed over the period of few years, from binary classification of HER2 positive versus HER2 negative, then HER2 positive, then HER2 negative, which is then became HER2 low, and then complete HER2 negative. And from again HER2 0, we have carved out something which is ultra low because of the Destiny 6 trial. So this is what we are doing today, and this is the onus now lies on pathologists to do this interpretation properly. So the things have changed significantly. So the HER2 positive ones remain like that. As I already mentioned, HER2 low is a category when we on ISC say 1+ staining, or there was a 2+ staining which is on FISH or ISH is negative. So that is again HER2 low. And in a category which was 0, which the cells with less than 10% of the cells having incomplete staining, we say HER2 low. And if there is no staining at all, it is HER2 null. So this is what now the CAP recommends again. This is repetition of the 2-3 slides are actually repetition, but it's good for if there are any pathologists, even for the clinicians to understand what is happening here. So this is what the guidelines are there. I'm not going to talk about NCCN guideline. Dr. Bajpai just mentioned about it, and it is now very important that as a pathologist, you need to say whether it is 0+. It need to say whether it is 0 or a 0+ or 1+, because all these categories will have different treatment and the different connotations when they are going to consider, or you people are going to consider for treatment. So the key takeaways from this talk is for a pathologist that they need to use different magnifications, for low power and high power to check for the intensity, the number of cells, and the completeness of the membrane staining and all. And they have to see the extent of the staining, and they have to pay very close this thing for the cutoff points, like as I just mentioned, 10%, my 10% can be different from somebody else's 10%. So if I have a problem with that, it is like I need to show it to my colleague or somebody who knows about how to report it, so that the two people can assess this and give the proper cutoff, so that you will have 1+ and 0+ category nicely segregated. And of course, there are guidelines now, ASCO CAP guidelines. You should go back to, and check what has changed. There are so many things which have changed, not just in the HER2 low cases, but even regarding 2+, there are categories which are now included in 2+, which were not there in earlier. So it's, I think, very, very important if you are a pathologist that you go back to this guidelines carefully and check it and change your pattern of changing. And even your report, if needed, you put the footnotes or the comments saying what it is and how it should be interpreted for the oncologist to know. And as an for oncologists, as I'm already mentioned, I will again reiterate that you should check with the pathologist what platform they are using and which antibody is using, because this HER2 low or ultra low, this diagnosis is considered the like a companion diagnosis only if it is done on Ventana with 4B5 antibody. However, I think ESMO has also included if some DACO platform, which is Omnis platform, and I don't think it is now very easily still available in India. If it's done with Hercept a kit or assay, I think they are going to allow it that you can still diagnose them as ultra low or low, HER2 low. So with that, I will stop, and thank you so much for patient listening.
Very good talk, Dr. Pravin. I have one or two questions which are, all the time coming into clinics with all this plethora of the data. So my question is that, you very rightly spotted that, it has to be a companion diagnostics kind. But what if, that is not the case and it is showing HER2 low? Do you suggest that we have to strongly repeat the testing that is we are facing in clinics?
So you are asking me if it is not done on this platform.
Correct.
And with that antibody, but somebody says it is 1+
yes
or 0+.
Yes.
I would say if you are going to give this drug, you need to repeat it from the platform.
Done. So this is very, this is important, and I think this message should go. Second, because at times patients are reluctant to repeat it, because if they're coming from somewhere opinion, then based and they want to take the drug, but they don't want to repeat the test. So that has to be clear that,
repeat test cost will be not more than 2,000.
No, it is not always the cost. They feel logistically, challenged because a few more days will go and etc. So that's where I feel it is important. Second, also there are many technicality involved, in cold ischemia time, the fixation.
Yes.
So if there are some outside, even if now with this in particular platform, are we really sure that this is the right test?
So I would say that if it is properly fixed and properly processed tissue, we have taken care of cold ischemic time and everything, then it is interpretable. Now, this is the challenge in India that most time, even in my setup, we get something from outside already fixed or processed. Then that's a challenge that I cannot, do something about it. But at least things which are fixed, or the biopsies, biopsies usually get fixed immediately. And most often now everybody is using neutral buffer formalin, so that has become quite standard. And then if it is done on an appropriate platform, I would say okay, it is good. And if it is not interpretable, or there is issue with the fixation or the processing, at least in my report I always mention that that there is a compromised interpretation because of these reasons. So I think you should, even if you're a pathologist, if you have a dialogue with them, at least you have that dialogue and ask them if there was anything compromised and whether they need to repeat it with a repeat biopsy or whatever it is.
So I think, isn't it more sense that, with the availability of or, or other therapeutic relevance of such treatments, especially if there is something from outside, maybe the way you guys are writing a footnote, an additional thing of that, reasonably good fixation or reasonably not good, something of that sort that gives up, because, every time it is difficult to talk also. So that would be
Yes,
those practical points, I think. Uh,
yeah.
that's all. Thank you
Yeah, I
very
agree.
much.
So,
Yeah.
unless you people insist, pathologists are not going to write it. So you always have to insist, because we learn from you also. There are many things which come, you are more abreast with the, the updates. So if you ask them, what is this? Why you're not written this?
Yes.
Immediately we follow. I mean, that's how it
Yeah.
is. We also update ourselves because of the clinical progress.
Yeah, because I feel there is a lot of overlap. For example, less than 10% faint staining is 0 plus. But if it is 11-12%, then it is 1 plus. So then,
Yeah,
there is a lot of
I
difference
know.
with this, and even with 0 or plus 1. Also, when we are asking for second pathologist's opinion, if there is a dispute, whom should you rely? We want third person. So these are the pretty practical issues, and that has to be come to a consensus, because now these drugs have shown their importance, and we need to carefully choose which patient are really needing it.
I agree with you.
Thank
Thank
you.
you for that wonderful discussion. Pravin, thanks
Thank
again for, just discussing this topic. It's a new topic for all of us. We all are learning. Still, things will evolve here, I feel. But giving us the complete picture and, hammering us again with the ultra low. What is ultra low? Now we have understood forever what is ultra low and low. Uh, of course, just a question that most of the labs in Mumbai, they are having this companion diagnostic test, Ventano. You feel it is
So actually the Ventana platform, most of the labs are using now. Yes.
okay.
So if your pathologists are mentioning that this test is being done on Ventana with this antibody, you should take it as a companion diagnostics. If it is not mentioned, then I would say pick up your phone, call them and ask what platform and what is, which
And
antibody.
setting up this platform is not very costly, I guess, is what I understand.
No, not at all. So most of the
So,
labs are using it. So it is
so
not
all
only used for this, it is used for other IC also. So
fair call.
it is all, yeah.
So which means that all hospitals, all labs, they should have this platform now for HER2 testing.
If you want to treat the patient for this
No,
drug, I
we
think,
may treat, we may not treat, we may just generate the data also. But if you're
yes,
doing an HER2 testing, this is the platform we should use then.
yes, correct.
Okay, understood.
Yeah,
Okay, fair call. Thanks, Pravin, again. And it was nice interacting, meeting you. Now we'll change the
thank you.
flavor and we will just jump and change the gun to metastatic colorectal cancer. And what's new? What is the new paradigm? We have our colleague, Dr. Kaushik. He's a medical oncologist from INS Ashwini. Uh, Hi, Dr. Kaushik, you're there?
Yes, sir. Yes,
Nice. Nice
am
to
I
see you.
audible, sir?
Yes, you're audible. Your slides are visible. You can just, magnify the slide. Yes.
Thank
Great.
you,
You
sir.
can
Thank
start. Yeah.
you, Muzammil, sir. Thanks for the opportunity and just taking few minutes of attention from breast to colorectal cancer. So the topic for which has been given in the sponsorship slide is the new paradigm in the management of metastatic colorectal cancer. And we know the treatment of CRC has evolved over the last 2 decades, and more often it's driven towards the sidedness of the tumor or the molecular biomarkers, particularly RAS, BRAF, MMR, MSI. They have all come into play in the last 1 or 2 decades, and there has been change or addition to the chemotherapy. And we have seen with the addition of anti-EGFR or VEGF, with chemotherapy, the overall survival has improved in metastatic CRC, and it is to the tune of 30 months. However, some post-hoc analysis of these trials, particularly the RAS wild type, maybe a CalGB or a FIRE3, it has some conflicting results. Like FIRE had a improvement in the overall survival when cetuximab was combined with for chemotherapy backbone when compared to bevacizumab, but similar benefit was not achieved in CalGB. So there was a need for a prospective trial, and there comes the role of this paradigm in this data. It is the first prospective trial to show the superiority of the panitumab when compared to bevacizumab with standard chemotherapy, particularly in the RAS wild type and left-sided colorectal cancer. So just going to the trial design, this was the paradigm trial design, the phase 3 randomized multicenter trial, where the inclusions were all with unresectable disease with no previous chemotherapy. However, the adjuvant chemotherapy they have completed more than 6 months. They were allowed in trial. Age was up to the 80 years old, and performance rate was 0 to 1. And they were randomized in 1:1 randomization towards chemo backbone was modified 12 of 6 towards panitumab versus bevacizumab. The stratification was age cutoff from 65 or more than 65 and liver metastasis whether present or absent. The primary endpoint of this trial was overall survival, particularly in the left-sided population, and it was a hierarchical analysis. Only if it is significant in the left-sided, then they were analyzed for overall population regarding the overall survival benefit. The secondary endpoint was PFS, response rate, duration of response, and if they were achieving a resection, then R0 resection rates. So this was the randomization data. Total the trial recruited from 15 to 2017, a total of around 800 plus patients, almost 400 in each arm, and particularly the left-sided population were up to 80%. So overall, for 400 distribution, and majorly they were left-sided. 80% of the population to the tune of 312 subjects were left-sided population, and median follow-up was 5 years, and the data cut of the trial was in Jan 22. Almost we had a 5 years follow-up. As said, the statistical analysis, it was a hierarchical pattern. The first primary endpoint overall survival was seen in left-sided population, and if this was achieved, then the overall survival was seen in overall population with this cutoff value. Baseline characteristics were matched in pretty all overall populations, both the left-sided and the right-sided, which was in 20%, around 80 patients in right-sided, and majorly, that is around 312 subjects in left-sided populations. Number of metastatic organs, more than 2 were seen in almost half, more than 50% had more than 2 metastatic organs, and only liver being a metastatic organ in approximately around 65 to 70% of patients. In 20% of patients, only liver as a single site of metastasis. Almost 60% had prior tumor resection done in this entry participation. So this was the overall survival which was seen, and primary endpoint, the overall survival in particular in left-sided population, we can see panitumab when compared with bevacizumab along with the modified FOLFOX, there was an improvement in median overall survival from 34 months to 37 months with a hazard of 0.82. We can see the small separation of the gap or the Kaplan-Meier curve as the time goes on with almost 18% risk in reduction death. And based on these ones, this overall survival, as I said, there was a 3.5 months of improvement in overall survival. They looked into the overall population, how the benefit of overall survival was achieved. And there is a benefit of overall survival from improvement from 31 months to 36 months when bevacizumab versus panitumab, 36 months in panitumab with a hazard ratio of 0.84. Subgroup analysis, again, left-sided tumors, improvement across the subgroups, whether they had a liver metastasis, the number of metastases to organs were more than 2 or not, and primary tumor-sided, but definitely yes, left-sided, there was a gross improvement. And in overall population also, when we had subgroup analysis done, again, there was an improvement in all the subgroups, particularly the liver metastasis or the number of metastasis organs and the tumor-sided means definitely. So there was an improvement in all left-sided and overall population in all the subgroup analysis. PFS was almost same. There was no much benefit in the PFS. It was almost same as the bevacizumab along with modified FOLFOX therapy. It was to the tune of 13 months in the left-sided, and in overall population, it was to the tune of 12.5 to 13 months. Almost the similar PFS in both the left-sided and overall population. Efficacy outcomes important here is interesting is the response rate which has been improved when panitumab was compared to Bev with the chemo backbone, the response rate, the difference was 11%. The response rate improved from 68% to 80% in left-sided population, and also in overall population, there was improvement to the tune of 8% above from 67% to 74%. So there was a difference in the response rate to the tune of 11% in left-sided and 7% in overall population. Rest all remains same, disease control rate, the duration of response approximately same. The R0 section, if someone has taken up for the conversion surgery, there was some improvement up to the tune of 5% in both the set of population. So adverse events was almost familiar as we know with the panitumab. Majorly it was a rash, stomatitis, or hypomagnesemia, decreased appetite, or fatigue, and bevacizumab because all hypertensive related adverse events, epistaxis, hypertension. Subsequent treatment again, this is again important. In those both set of tumors, approximately 80% were received the second line of therapy, and that too after second line. Again, third line around 60% were eligible for some form of third line of therapy, and fourth line around 40%. We know these colorectal cancer patients they do receive second, third, and fourth. Here also the 40% of patients were eligible for some form of fourth line therapy because either a cytotoxic therapies or a combination of VEGF or EGFR inhibitors or TAS or regorafenib. Overall, these were the subsequent lines and patients were eligible in this set of patients. OS, no much improvement in the subgroup, particularly. This was the exploratory analysis what they have done in the right side population. You can see no much of it was actually detrimental. The 20 months in the panitumab by 2 compared to bevacizumab, it was 23 months. Even in the subgroup analysis, there was no much of benefit when we seen in the right side population, as we know. Even as seen in the OS, the PFS, the benefit was not seen in this exploratory analysis in the right sided population. It was seen as per the other trials also. So overall, concluding this phase 3 data, paradigm data, demonstrate the superiority in the first line combination of the panitumab along with the modified Folfox when compared to the VEGF, that is bevacizumab, in left-sided and overall colorectal cancer, where there is improvement in median overall survival from 34 months to 37.9 months, the hazard of 0.82, and overall also patient there was an improvement in median survival with a hazard of 0.84. Here in this set of patients, we can see that median overall exceeded 36 months in the first line, what we have seen in this left-sided, particularly these set of patients. So PFS was seen equivalent in the both the arms. Important was the response rate improved with the addition of panitumab along with chemotherapy in the left-sided population. Response rate to the tune of around 12% improvement in the left-sided population. Safety signals were almost similar, which we have seen. They have used panitumab. No much of difference in the safety signals in the both groups. So this data supported the use of panitumab in combination with the chemo backbone, that is particularly modified Folfox as a first-line therapy in this set of patients with RAS wild type and left-sided metastatic colorectal cancer. So this was just a revision for us of metastatic colorectal cancer. Thank you, sir.
Thank you, Kaushik, for that lucid presentation on the take on the panitumab data. Now we are a little bit overshooting the time, so with the thing in mind, we will start with the panel discussion. We are having a case, which is actually a case based on the current discussion today, hormone positive and HER2 low. I would like to invite my panelists, Dr. Nilesh Lokeshwar, Dr. Jyoti Bajpai, Dr. Vaibhav Chaudhary, Dr. Subhash Ranjan, and Dr. Pritesh Munot. I think everyone is logged in. And someone can share my slide because I am having difficulty of sharing the slide from here. We'll try to not repeat quite a few slides which have been provided to me because that has been already been discussed. We'll just go to the case directly. Next slide, please. So we start with this case, a 50-year-old female postmenopausal with a right breast lump. It was on biopsy and IDC grade 2, ER/PR positive, HER2 negative, which was ISC 0. Now that we are supposed to mention. Clinical T2N0M0, she received 4 cycles of neoadjuvant TC regimen. Why was neoadjuvant given? I have no idea. In clinical practice, I think the panel will agree. We will not do a neoadjuvant in this subset and go with surgery. Anyways, so this patient, after a neoadjuvant TC, underwent a BCS followed by radiation and adjuvant Letros. Germline was negative, testing and hence patient completed 5 years of adjuvant Letros in July 2019. Next slide. So in February 2022, she presented with severe back pain and the MRI was suggestive of bony mets and she underwent further testing. Next slide. So this PET scan very obviously showed a lot of disease we can see in the lung, pleural based lesion with parenchymal nodules. There is a liver lesion. The left lobe is quite significantly involved. Some bony metastasis, sclerosis is seen. Next slide. So she underwent a re-biopsy from the liver and it showed an ER positive 90%, PR positive 85, and HER2 1 plus and FISH negative. So this was different from HER2 0, which was there on day one. And Ki67 was 60 to 70%. We don't have the information on the day one Ki67, whether it was high on presentation also. Next slide. So this is the first question to my panelist. Do you typically re-biopsy a patient in such a setting? More likely the answer is yes, but I would like to hear anything different. Dr. Nilesh, you can take this one.
Yes, especially a patient who's relapsed after such a long time, I would definitely biopsy both to check the ER/PR as well as the HER2. We know that both of them change quite often in almost 40% of patients. So before planning the next line of treatment and prognosticating, I would definitely do a biopsy in this patient.
Anyone having any difference of opinion can just chip in so that we avoid repetition. So I think the panel agrees to this, what Dr. Nilesh has said, and this is what we do typically. If there is a long gap and if the biopsy is feasible without much of risk, we do a repeat biopsy as some significant changes in the HER2 ER/PR is seen. Next slide. And this is what Dr. Nilesh was referring to, that if you talk about particularly HER2 low, which is HER2 testing, which is today's discussion. Otherwise, ER/PR is a separate discussion altogether about the concordance, discordance, and the way it evolves. But this was an interesting paper, evolution of low HER2 expression between early and advanced stage breast cancer. A HER2 ISC score has increased from primary to metastatic tumor in 44% of the patients, which is significant. And HER2 low to HER2 zero also was seen, which was seen around 22% of the patients. And low HER2 expression is dynamic and maybe enriched in the advanced stage setting. So as you become metastatic, your zero can become HER2 1 plus or maybe beyond that. And this beautiful diagram on the right side very clearly shows that there is a significant percentage of population which will become HER2 low from HER2 zero at presentation. Next slide. And these are the several factors that suggest the importance of retesting. We have discussed this on ample platform. When the receptor status of the primary is not very clearly known, if the primary tumor is heterogeneous, metastatic evolution is unusual as compared to tumor characteristic, meaning the behavior of the tumor, if newer therapies are available like TDXD, if the initial test was performed more than 10 years, which Dr. Nilesh mentioned, and in this case particularly, and if the infrastructure can support safe and timely biopsies with a very short turnaround times. Next slide. And this already have been discussed in the Destiny Breast 06 subset analysis. Efficacy and the HER2 prevalence is similar, irrespective of the tumor location and the type of sample collected. So we are comparing primary versus metastatic or biopsy versus excision. It was similar. At least one ISC report with a discrete ISC score and percentage of the cell stain is required in the metastatic setting. This is what the new standard of care of reporting of HER2 is followed, which Pravin mentioned. Next slide. So coming back to our case, so this patient did had lung and liver metastasis, which we saw, and rebiopsy we have just seen. This patient was started on palbociclib plus anastrozole. Next slide. So the question to my panelists is that, do you agree with the first line choice of therapy in this metastatic setup? Dr. Jyoti Bajpai can take this, followed by Dr. Vaibhav. Dr. Jyoti is there? Dr. Jyoti Bajpai? Vaibhav, you can take this.
Yeah. So I have my own apprehensions subjecting this patient to PAL-based plus anastrozole, right? So my question is, when was the last this thing given or AI given?
2019.
And now after 5 years of stopping that, she has come back like this, right?
More than 2.5 years. So she relapsed in 2022.
Okay, more than 2.5 years. So, okay, yeah, actually, theoretically, this is correct, whatever has been started. But the thing is, the way it has come back and the magnitude and the tumor burden seems to be quite a lot. And apart from that, there are two outliers. One is the Ki-67, which is quite high, which is obviously, and the gain of kind of a HER2 is also 1 plus. So here I would be more comfortable going ahead with some chemotherapy here because if she fails and she fails very fast, but then we do have our definitions of visceral crisis, and that also we need to take into account. So if there is some issue with the liver functions or patient is having too much of symptoms, I will rely more on the chemotherapy. That would be a taxane based chemotherapy. And beyond that, yes, we always have that option of HER2 1 plus, so then HER2 would be a good choice.
Sorry,
Point well
Muzammil,
taken. Yeah,
you were
Jyoti.
asking, yeah, I was.
Yeah. So this patient, na, whether a CDK4/6 with an AI is the preferred choice, whether it is right or whether you will differ.
So I think, I would also want to see the clinical signs and symptoms. And even if it is not a frank visceral crisis, whether it is an impending crisis will
Impending,
also,
yeah.
kind of take into account. And if it is an impending crisis, like slightly altering of OTPTs, etc., then I will more err towards using either chemo or even, in this HER2 low population, I may think for in today's context, even NHER2. But if it is plainly no, no enzyme alteration, it is just few lesions, and there is then this CDK4/6 is also a reasonable choice.
Very well taken. Now, Dr. Pritish, your take on this?
Hello, sir. Yeah. So I think first line CDK4 inhibitor with AI should be the go-to, is what I feel, sir. Even if it is visceral crisis, I think trials have shown that they do what do you call, they do well in those scenario also. But NHER2, I'll keep it for second line maybe. And chemotherapy, I'm not very keen, sir, when I have the option of CDK4 inhibitor plus uh, AI.
Okay. So a different way of looking at the same thing. Dr. Subhash Ranjan can chip in his take on this. We have Dr. Subhash Ranjan. Okay. So I think Nilesh, your final word on this?
So this patient has high volume disease, but is not in visceral crisis. Got a strong ERPR positive. I'm absolutely comfortable giving a CDK4 with either anastrozole or sometimes even maybe fulvestrant. But I don't think there is a very strong case for chemotherapy. We don't know the reports and all those things, but based on what you have explained, I would be comfortable using. My choice of CDK4 may be slightly different. I may prefer something else, but by and large, that combination suits well for me.
Fair call. So we have some kind of a tie here between choosing directly jumping to the CDK4/6 plus AI versus looking back and watching. I think both the ideas look quite sensible, because the whole problem here, what Vaibhav and Dr. Jyoti was trying to point out, was that there is a very thin line between how you define a visceral crisis versus impending visceral crisis. So there are some definitions about the labs and the breathlessness, and this all is some subjectivity to it. So I think that benefit of doubt, I think we will give to the treating physician who's seeing the patient there. And after examining the patient and labs, and they feel that, well, this patient is going into an impending visceral crisis, if they choose chemotherapy or maybe TDXD, maybe it a fair choice is what I take, from my end. But our clinical practice has been that unless and until there is a gross, visceral crisis, just visceral disease, we are avoiding chemotherapy in most of our patients. Is that a fair assessment of what we discussed?
Yeah, I
Yeah,
think
I
so.
Anyone in
mean,
the
yeah. So I think, Muzammil, you are absolutely spot on, and I just want to, draw the attention. At times what happens that, the pace of the disease, and if you're closely watching a patient with multiple liver lesions, so couple of times at least in TMH, I have seen, and because Vaibhav also with there, so perhaps that's what is the reason, we are coming with that. That in no time, we find that at present patient is not in frank crisis, but a week or two goes, and this patient who is impending towards that may become frankly. And in that, although there is some data of CDK4/6 inhibitors in visceral crisis also, but in frank crisis, I would err towards using other therapies which are more fast acting. So that's what is my take. Although there is some data, I completely believe. And
I
that's where
agree,
the
agree,
medicine
agree.
is, medicine's 2+2 seldom comes 4. So that's why everybody's lens is little different.
Point well taken, Jyoti, because this is what we see, and the data you are mentioning is phase 2 and some small. It's not a very large body of data for using the CDK4/6 in visceral crisis. Okay, so I think taking the call of giving chemo based on the patient's overall appearance on examination and labs will possibly make us more wiser in choosing directly a CDK4/6 AI versus chemo in some group of patients.
Yes, Dr.
Next slide.
Dr. Muzammil, I
Yeah,
had
Vaibhav.
one query
Yeah.
regarding this particular very unique situation. Are there any proponents of doing NGS in this setting? Find out an ESR1 or PIK3. That might be a possibility because the grade is also very high. She's strongly ER positive, PR positive. And as far as I remember, I think Dr. Jyoti can correct me. There are certain guidelines now in place, I think to ESMO only. Then in MBC also, we can actually look at in particular situation for NGS to see for the marker of aggressiveness, why this tumor actually has changed its nature and become so aggressive.
So two things, Vaibhav, here. I'll just then Jyoti can chip in.
Yeah.
Is that this patient had a failure after 2.5 years, so it is not the typical one where I will jump to
Yeah, it's not
ESR1
resistance
immediately.
by definition. Yeah.
Yeah, so I may not jump for ESR1, but having said that, in clinical real world scenario, if you ask me, with such high Ki67 and the way it has turned to HER2 1 plus, I would be if facilities and opportunities available to do a NGS on this at this juncture. So I will agree with you honestly in this case. Jyoti,
Right.
your take on this?
Yeah, I think I also, because ultimately in clinics we cannot be very watertight compartments kind. We have to be dynamic and we have to see the scenario. So I'm fine with that because guidelines also keep changing. They are in evolution phase, the living guidelines. So today, which is not accepted by a majority, tomorrow it is. So we have to take the clinical cognizance all the time. I would prefer to do an NGS in this time, but maybe by the time it will come, we will
Yeah.
not. I will not wait. I will
Not
act
wait.
fast.
Yeah.
Understood. Nilesh, your take on this, since this is an important question raised by Vaibhav.
So yes, I agree that, but the main thing we are really looking at is that ESR1 mutation, the PIK3CA mutation, and probably a germline BRCA. As these three things would probably alter therapy. Having said that, having an ESR1 mutation today, none of the drugs are available to us. But yes, it does give us some hope down the line, or possibility of a clinical trial. I would do it.
So I think the panel almost concurs on with some pinch of salt about doing based on the availability of the resources. Next slide, please. And this slide we all have seen. This is a wonderful master slide capturing the impact of CDK4/6 with endocrine therapy in first line, second line MBC, which is ER positive. And this runs across all the three available agents, the amivaciclib, palbociclib, and ribociclib, with a very impressive hazard ratio across the trial of less than 0.5. So it's a 50% reduction. I think we'll skip this slide. We have seen this in many presentations. Next one. Next slide, please. So visceral crisis definition and all we have gone through. So it's only when there is a breathlessness, symptoms, liver dysfunction, in absence of Gilbert syndrome and biliary tract obstruction, we define that as crisis. Otherwise, just having mets in the organs is not a visceral crisis, it's just a visceral disease, for which we all, the entire panel agreed that if it is only a visceral disease with no crisis, we are going to choose a lesser toxic regimen like AI with CDK4/6. Next slide. So this was the dictum: no chemotherapy unless visceral crisis. With this, we have dissected out in detail, and then either way we can be right and wrong, because that clear definition is somewhere a little bit blurred when it comes to impending crisis. So I think we'll skip this for the benefit of time. Next slide. So coming to the case back, so this patient had a progressive disease in the liver after 10 months. No rebiopsy was done here, and NGS was ordered here on the old block, and we showed a PIK3CA positive mutation. So my question to the panelists here is, we can start with Dr. Pritish here, that will you do a biopsy when it has progressed after 10 months? Suppose you have not done the biopsy earlier. Dr. Pritish Manot.
Hello. Yes, sir. So, if the biopsy, so you asked if the biopsy is not done previously, is it?
Yeah, meaning on the relapse when they started CDK4/6.
We did not
Will
do
you
a
do a
biopsy.
biopsy? Yeah.
So on the relapse, if the biopsy is not done and once it progresses, I'd definitely do a biopsy, sir, to check for ESR1 and PIK3CA mutation.
Okay. And suppose the biopsy was done at relapse and now it has progressed in 10 months. Will you do again a rebiopsy?
So, sir, this is hello.
Yeah.
Sir, so this is a slightly tricky situation in 10 months doing a repeat biopsy. Generally, this is what I've observed. Patients don't really agree for that. Most of the times, how much ever you convince. But medically speaking, we should do a biopsy to get these mutations done. But in a couple of patients, I've sent for blood for ESR1 and PIK3CA, sir. But I'd like to hear your thoughts, sir.
Dr. Ranjan, Dr. Subhash Ranjan is there. We can hear his thoughts on this. I think he has not joined, looks like. Dr. Jyoti can take this.
So I would prefer to do a biopsy whenever it is accessible, because there is always tumor evolution and the clones keep evolving. So I would like to see that, now the recurrence or the failure is with what predominance, and that would perhaps, help me in taking a decision. So I would prefer to do a biopsy. That's what is my take.
Vaibhav, you will agree with Jyoti here?
Yeah, I totally agree. But if the patient is denying a biopsy, there is logistic issue. Then what you have done, your old block NGS, it already had shown PIK3. So we have a therapy for that patient, and PIK3 status won't evolve, won't change mostly. So yes, both the ways it is correct. If logistically correct and patient is agreeing, then yes, go for a push for a biopsy. If not, then yeah, this also will work out for me.
So I think the panelists agree that if feasible, do a biopsy because evolution can occur even in short span also. If not, then because the primary event PIK3CA is a very early event,
Yeah.
it doesn't changes much with
Thank
time.
you.
It is good to go ahead with the NGS because there is a specific drug available for it. Suppose if we have done an NGS on presentation and there was a PIK3 positive, would your first line change? Dr. Nilesh, you can take this.
No, my first line would not have changed even if there was a PIK3, but my prognosis I would been a little concerned about the prognosis. These are more aggressive tumors. So if you see this patient, she actually had an endocrine sensitive relapse, but has not done well. And this could be the reason why she's not done well.
Perfect. Perfect. So I think move to the next slide, please. So if the patient presented to you today, what will be your next line of therapy? Alpelisib with fulvestrant, everolimus with ET, rechallenge with CDK4/6, a different one, or any other choice you want to suggest? Nilesh, you can start this.
So, I would look at the disease burden, patient's general condition, and these factors, which are very important to me. Now, guideline-wise, we have the option of using alpelisib, fulvestrant versus some other chemotherapy versus Enhertu. Alpelisib, fulvestrant, we've all burnt our fingers. We've used it in multiple patients. It's a very poorly tolerated drug. If it's not the rash, it's the hyperglycemia. And I have rarely seen excellent responses. So I have almost stopped using this combination. So my choice is between either switching on to fulvestrant versus a second line CDK4. I could probably shift from palbociclib to abemaciclib and change to fulvestrant, or a single agent chemotherapy, or Enhertu. Assuming this patient is low low HER2 positive, uh, I would give some priority to Enhertu at this junction. My personal experience also has been that in HER2 low, using Enhertu after multiple lines of treatment doesn't really work that well. This patient is probably at the sweet spot where I would expect her to have a good response with Enhertu.
Excellent. Jyoti, your take on this?
So, I would choose either as a low HER2, Enhertu, or I also used alpelisib with fulvestrant in a couple of patients, but we have to stringently monitor. That's what I agree with Nilesh that it's a bad drug for toxicity, but you may start with a low dose and then escalate something of that sort. So in that way, in some patients, I have seen a good response. So that's what is my experience. But I completely agree that hyperglycemia is dreaded, and that's where you have to be very carefully monitoring things. So NR2 has widened our armamentarium in this situation. I'm not a fan
Vaibhav?
of
Yeah.
changing CDK4 because I believe they are sister drugs.
Yeah, Vaibhav, your take?
Yeah, obviously, I totally agree with Dr. Nilesh that alpelisib is an evil drug, and we all have burnt our fingers. But then, what do we have right now? Because fulvestrant obviously has not been used. She is strongly ERPR positive. So, any thoughts about capivasertib whenever it is available? I think this is a situation because I have handled it in trial setting. It's not that bad as compared to alpelisib, but not a vast use. I had 3 or 4 patients, so that might be one consideration. But if we are losing battle, patient is going into kind of an impending visceral crisis, the huge tumor burden, already the tumor burden very high to start with. So then yes, NHER2 would be a good choice.
Suppose there is no availability of NR2 because of financial reason, no taker for everolimus and ET.
No, I'm for it also in that situation. So it is also a good drug. Again, only it has now become, because of we have now problem of plenty. So that's where.
Yes.
So again, as he rightly said, capivasertib is also a choice, but because it is not available, I didn't say that. But that is
Mhm.
also one of the choice, and it's better
One more
tolerated than alpelisib. So the everolimus is a poor baby. It's coming down and down, but it is also, we have used in many patients that it is working. Yeah.
Yeah, it's a lot of biological rationale for using everolimus. It's down
Yeah.
in the pathway, so there are a lot
Yeah.
of scientific rationale. Again, the dose 10 milligram sometimes becomes very
It's tough.
challenging, honestly.
It's tough.
So in Tata Memorial Muzammil, I did that analysis, and we found that 10 milligram dose is a very toxic to our patients, and our dose, median dose was found to be 7.5. So 33% patient requires dose reduction, and we
Correct.
manage it like 10 alternating with 5. That was the dose.
Right. Nilesh, do you use everolimus now in your practice? Nilesh? Okay, I think we'll move ahead with the next question. Next slide, please. So this is the data we all are aware about: alpelisib, everolimus, solar one, and then we have the bile, which is prior CDK4 exposure. We'll not go into detail. We have discussed that hyperglycemia, diarrhea, rash, and sometimes stomatitis. Actually, stomatitis also is troublesome in quite a few patients. But we have used this drug enough to know that it's an evil drug. But if we are pushed to the wall, I think we all have used it, and everyone has some handful experience. Typically, the benefit lasts for not more than 5 to 6 months, and it progresses on alpelisib. Next slide. This I will skip. Next slide. So when do you consider patient as endocrine? I think we'll skip this. This has been discussed at many platforms. Next. So this again we have already discussed in detail. When we prefer to do a target NGS evaluation at least in second line, and if not, then at least in third line. Next slide. Coming to the case, so this patient was started on alpelisib with fulvestrant. Again, the horrifying hyperglycemia, and then we stopped and then continued on fulvestrant. Next slide. So our real world experience of alpelisib we have really discussed. Next slide. So this patient continued on fulvestrant till June 2023, and then there was a progression of the disease. This looks more aggressive disease state right now, and was started on capecitabine single agent. Next slide. So if the patient presented to you today, what would be your treatment of choice in this patient? Continue capecitabine or some other chemotherapy like paclitaxel, nab-paclitaxel, or you will use the TDXD based on the breast Destiny 06. We can start with Pritish here. Pritish, your take.
Sir, at this stage, if the patient is stable and fit enough, I'd go for NR2 TDXD, sir. I would prefer that because the data is quite convincing. Yeah.
Correct. Vaibhav and Jyoti.
Yeah, affordability is the only issue. Otherwise, it's a no-brainer that we should try NR2 before, because that was the whole basis of the trial.
So I think Jyoti has already presented this data, and it's very convincing that if finance is not an issue, then I think TDXD is the right drug at this moment, and even maybe a prior line if possible in today's era. Next slide. This will skip. This Pravin has covered, Jyoti has covered the definitions and all. Next one. Next slide, please. Next slide. So we'll not go into destiny, but we know that with this new way of testing HER2, we have expanded our spectrum to almost 80 to 85% of the patient where TDXD can be an option. Next slide. Skip this also. This all data we have already seen. Next slide. Next slide, please. Next slide. Next slide, please. So Destiny 06, Destiny Breast 04. How do you position TDXD? Vaibhav, you can start with.
I think earlier the better, because as we go further down the lines, then the percentage of patients being eligible for further lines actually drop off. In breast, it is not much of a problem as compared to other like lungs or urinary bladder and all, but still there is a drop off. Some patients would be there who won't be eligible at that point of time, or because of lot of issues, logistic issues as well. So I would actually go with the earlier line.
Jyoti, your take?
Yeah, I think, the data is convincing, and wherever this drug is being used in, different settings, has shown a promise. My concern is regarding the cost. I think something should be done about that so that it should be able to reach to masses.
Sure, that eventually will happen. I think Nilesh was very clear that to use it in early lines, because his experience in the later lines has not been very great, which is true for all of us. So next slide, please. Next slide. Next slide, please. Next slide. So would you use TDXD in patient with HER2 ultra low? We have defined that subset already. Nilesh, you can take this, followed by Pritish.
So data-wise, yes, I would use it. Having said that, I don't think we are very proactively identifying ultra lows. We are still having reports of 1+. This is a situation where I would probably go beyond and speak to the pathologist, and I'd ask him, this is a patient who's been reported as 0. Do you think it could be an ultra low? And I would definitely do that as a exercise.
Pritesh, your take on this TDXD?
Sir, agreed with sir. I don't think we see that many patients with ultra low IHC. If we get, definitely I'll use. Maybe I'll discuss with the pathologist and get to know what the exact IHC status is. But we don't see that much, sir.
So I think worth talking to our respective pathologists when we meet them tomorrow about the platform they're using for testing HER2. If cost is not an issue, then we all should be shifting to Ventana. 4B5 is what I believe. Any comment on that from Vaibhav or Jyoti?
Yeah, I think, sir, most of the hospitals, our pathologist also said that now we do have that, and the cost wise, it is not much of a hassle. In Mumbai, at least, forget about the other cities, they are just small places where they don't have this access. But here, I think we do have that platform, but I'm not very confident of the ultra low reporting. And I have, to be very frank, I have not seen any report being labeled as ultra low till now. Lot of breast cancer I
Yes,
have seen since this data has come.
exactly.
So,
Same, same.
so yeah, so it's a hypothetical thing as of now for me
But
till the
it
time
should
I
be
get the
reported
green
now.
light.
Now with so much of push, it should be reported. Jyoti, your take on this ultra low?
Yeah, so I think stringently conducted, a good pathologist and who has been carefully all the technicality maintained, then yes, I would err towards using. I think you all are right that they are not being worse to report ultra low, and we are asking them, and then it has come. So what one patient I received when I objectively asked that whether it is ultra low, although still I didn't use in that patient because of some other reasons, but
Yeah.
that's what is the scenario.
I think the practical world is different.
Yeah,
It's,
yeah, yeah.
I think
Because
this
we
is
are
new.
always taking it with a pinch of salt that, whether all the technical demand, because very thin line, between the null and the zero. So I think that needs a proper training and proper reporting. And we also should be accustomed to see that kind of a thing. And then it will become a routine.
I think, since Pravin Mahajan has left the group, I think clinicians are moving faster than the pathologist when it comes to accepting science and newer updates.
Muzammil,
We
I
have to
think,
keep on.
they are not aware also many times that, this is the
Correct.
therapeutic relevance. Because when I insisted first, the pathologist actually wanted to know that why I want to trouble
Yes.
pathologist for that reason. And when I have given that, this is so much of that, and then, the pathologist was really convinced. Yeah.
Nilesh, what is your take when your experience with your centers?
Unfortunately, it's not being done.
Even for CNS tumors now, I mean the entire classification has changed, but I still see reports which is reported in the old pattern. So I think there is some push which will be required from our end to the pathologist. I will check tomorrow again in our hospital whether they're using the same platform or not, because we are just I've never seen an ultra low. So I think we'll check.
I think it is from from pharma point of view also they should conduct a proper
Correct.
training sessions
Evaluation and training,
wherein
yes.
there the pathologists and clinicians together have a dialogue. That makes a lot
Yes,
of sense.
correct. Makes sense. Next slide, please. Next one. So we all aware that now FDA has approved HER2 for unresectable metastatic hormone positive, HER2 low and HER2 ultra low. So this data we all are aware. It's this year's approval. Next slide. So how do you see that clinical practice will evolve in to ensure the identification of patients which are eligible for TXD in ultra low space? I think first testing should improve. That is what we all discussed. So we'll try to ensure that the pathologist make an attempt, and there is a protocol form then, and the platform is used which is approved platform. Okay, and I think this we have already answered. Next slide. This was the guideline and the new guideline framework given for the pathologist to report a HER2. We'll not go into details. I think we have covered most of the things. I think one last slide is about the sequencing. Please, next slide, please. So this is the last slide. One final word from each of the panelists. We can start with Dr. Jyoti. What do you consider as optimal sequencing in 2025 for this hormone positive HER2 low? You're on mute, Jyoti. Jyoti, you're on mute.
So I think we have already discussed that, if it is not in visceral crisis versus visceral crisis, how we will shift gears, and if it's not in visceral crisis, still CDK4/6 inhibitors along with the hormone partner. And if it is visceral crisis, perhaps our choices will slightly differ. After first line CDK4/6, second line, there are options. And if it is a stringently conducted test and there's a HER2 low, I would choose to use the therapy in earlier lines and HER2 if cost is not a major constraint.
Nilesh, your take?
So I think I'll just generally say that in a patient with HER2 low, I would prefer to use Enhertu in an earlier line. Many factors will decide that. I had a counter question. What dose are we comfortable giving Enhertu as? I mean, we know the calculated dose. Many of the patients would be ideally requiring to take 300 milligrams. Is everybody doing a rounding off to 300, or are we also giving 200 very often?
Yeah, I have one patient. She has been maintained for more than 8 months on 100 mg. Frail lady, 50 kg, rectal cancer, fourth line. So she has been doing well even with 100 mg because of lots of issues. First off, tolerance was not such a big deal, but the financial reasons and all. So this drug does have activity. That's the signal that even in lower doses also you can expect. 5.4, the more we go higher, more apprehension is with the toxicities, all sorts of toxicities, including ILD. So yeah, it's obviously we should try for a young fit patient for an ideal dose, but I think 4.5 would be optimal for most of the patients. 4.5 mg per kg.
I think,
Yeah.
creativity and perhaps our problem, our solutions. So toxicity is a concern. Toxicity, which is like organic toxicity, is also financial. So we have to take a individual. I think this is also precision medicine essentially. And we need to always do that. And perhaps the receptors get saturated at a lower level of the drugs also, which we have seen in many cases, even in IO. So I think that would be the case here also. That's what is my belief.
So agreed. I think Pritish, any other comment other than what the three panelists have said?
No, sir. I agree to what the
So just one
panelists have
final
said.
question, that if suppose the patient comes in visceral crisis today and you have Enhertu available with you, will you go for a chemotherapy or you will choose Enhertu?
Chemotherapy, sir.
Okay. Jyoti
I
and
would still go for chemotherapy, yes.
I would urge
Jyoti.
towards Enhertu.
I would give Enhertu. I've seen very good and very fast and very deep responses with Enhertu.
And especially
Vaibhav?
because, we are asking
Yeah.
about this population, which is ER positive and HER2 low. So this population not very chemosensitive also. So this was an unmet need always. So now we have a, kind of a marker-driven therapy. So that's where I feel we are more comfortable.
Yeah, I would give HER2. It is ultimately chemotherapy only. So I don't see the advantage of chemotherapy over HER2. It is more directed form of a chemotherapy, and it's quite a decent payload that it gives. So I am happy with HER2 if patient is affordable in this setting.
Do we have enough data to say that it can be used as a frontline vis-a-vis chemotherapy in visceral crisis? I'm talking about.
If first line is not out of question,
Not first line. Not first line.
not first
I
line.
thought you
So
must do it like
first line you
No, I'm
asked,
talking
right?
about first line. Patient
No.
came to
First,
you as a metastatic tumor burden with crisis.
so
Because
there the thing is, sir. Yeah, I would like to take this. There the thing is, if it is HER2 2+ fish negative, I would be more confident in pushing for, and a lot of things are there. But it is frank triple negative, then yes, I have more trust on my platinum there. ERPR
any
positive are
data
there.
to
Yeah.
say that HER2 2+ is negative versus
2+1+ are
IST 1+.
equal. That was the data. But
Correct.
if ERPR will decide basically between these things, for me at least, because if this is turning out to be triple negative, then yes, I would have more trust on the platinum kind of a thing.
Nilesh?
Not in first line. I wouldn't use it.
Yeah. Jyoti?
So I think I would say the space become blur with these data because now we are not very 100% sure because we know that in this ERPR positive population, giving chemo is also not that great an idea. And similar time we are unsure because the data is emerging and it is not very robust. But there is a rationale, I would say that this patient is HER2 low, and there is enough data which suggests that 1+ versus 2+ doesn't make more difference. So again, the crux lies that how sure you are about the HER2 low status as and if there is a stringently conducted pathology and you are there, then I would say today both are the options.
Yeah, but my
Suppose,
my
And with
concern.
a detailed discussion to the
Yeah.
patient that this is the data and all, and we are never sure that this will work or other one.
Yes, ma'am, but my question is, would we, if we are giving for first line visceral crisis, I actually am not aware of any data, even this trial also, patients, I don't think we were having visceral crisis. First line, forget about the first line, even in
So
second line
that's why I'm
also.
saying
Yeah.
above the space is blur. I've never
Yeah,
said that the
yeah,
data is there.
yeah.
I said with this data, the space become blur because now we are thinking
Right.
that perhaps it will work, but the
Yeah.
data is not robust. But
Yes.
but
perhaps that
for
dialogue
the
should happen that because
yeah.
many times in these visceral crisis patients with strong ERPR, even our chemo doesn't work. But
Yeah.
we bound to give that because of the data is there. The similar situation I will tell you that and sometimes back when there are 1 to 3 nodes and it is ERPR positive, we tend to give chemotherapy all the time. But now there is an oncotype DS which is mature. And now we are trying to see that whether this is really indicated. So,
No,
we maybe in some time that kind of a data will emerge. So right now the
but
space is blurred. That's what
yeah,
is my take.
suppose with the same information, and this patient especially had a 70% Ki-67. If you have that data, would you immediately change and take one side and the blur will become more clear?
So, Muzammil, you're not going to get any phase 3 level data in a visceral crisis
I
ever.
know. Yeah. So I'm telling you that
Absolutely.
maybe simple Ki-67 can help you in tilting towards one side. I will agree with Vaibhav, what he said there. I think the data is blur, but I think something as simple as Ki-67 may, make the difference in taking a call for NR2 versus chemo in some subgroup of patients. I think it was a wonderful discussion. We did cover some points. The highlights are that with this, impressive data of Destiny Breast, first 04 and now 06, and of course, defining the new subgroup of ultra low, I think they've just expanded the spectrum of patients who can be benefited from the HER2. And I think with this note, I will thank all the panelists, Dr. Pritish, Dr. Jyoti, Dr. Nilesh, and Vaibhav. And I will hand over to the organizers for the final comment and closures. Thank you.